to Report Back from ASCO on Metastatic Breast Cancer with Dr. Linda Vahdat. I'm Ivis Sampaio, the Senior Director of Programs at SHARE. Before the presentation begins, I'd like to tell you a bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 43 years by offering the support of those who have been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. During the presentation, all participants will be muted. When the presenter finishes speaking, we will open up for a question and answer period. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember, the presenter is unable to give specific medical advice, so please keep your questions in general nature. This webinar is being recorded and will be available on the SHARE website soon. Now, I'd like to introduce our speaker, Linda Vahdat.
Hi, Dr. Vahdat.
Yes.
I just made you a presenter.
Okay, yes.
Dr. Vahdat, we can hear you.
Okay, just give me 2 seconds. I need to get to my first slide here. Sorry, guys.
Okay, and I'm just going to say your bio very quickly.
Sure.
Dr. Vahdat is the Chief of Cancer Services and Head of the Department of Hematology Oncology at the Memorial Sloan Kettering Cancer Center, Norwalk Hospital Partnership. She is a member of the Breast Medicine Service at MSK and a professor of medicine at Weill Cornell Medicine in New York City. Dr. Vahdat earned her undergraduate degree from Barnard College, Columbia University in New York City, and completed her medical degree from Mount Sinai School of Medicine. She remained at Mount Sinai for her residency training in internal medicine, after which she completed fellowship training in medical oncology and hematology. In 2014, she completed a master's degree in business administration at the Sloan School of Management at MIT. Although a translational breast cancer medical oncologist by training, Dr. Vahdat's expertise is in drug development and has been involved in the identification, conceptualization, design, and conduct of phase 0 through 3 clinical trials of new therapies in high-risk adjuvant and metastatic breast cancer patients since 1994. She has led 2 separate drug development efforts that led to the FDA approval of 2 drugs active in metastatic breast cancer, and her team has taken the lead for at least 2 other drugs that have a high probability of success both in triple-negative breast cancer. She founded the triple-negative breast cancer clinic at Weill in 2014, and she then founded the first one in Connecticut at Norwalk Hospital as part of the Western Connecticut Health Network. We are very pleased to have Dr. Linda Vahdat present today to you. Thank you.
Well, thank you very much for inviting me. I'm very happy to sort of to share what happened at ASCO this year. And that's interesting. Why aren't my slides going? My slides are not advancing. Okay. Oh, okay. Let's try here. So we talk about ASCO, and I just wanted to make sure we're all on the same page and that everybody knows what ASCO is. ASCO is the American Society of Clinical Oncology, which is the largest oncology professionals organization in the world. And there are several meetings during the year, but there's always the big one every year, the last weekend in May. And this year, there were about 40,000 oncology professionals, and those are oncologists, nurse practitioners, nurses, fellows, trainees, students, drug development, pharma partners, advocates. It's an opportunity for everyone to get together. And this just sort of gives you a sense as to the big exchange of information that happens over those 5 days in Chicago. As you can see down at the bottom left, these are the poster sessions, which I would say are the most interesting sessions because they really show you all the new things, and it's an opportunity to interact with all our colleagues. So it's really a great time. You meet old friends, you see what's happening, and hopefully to bring a lot of good information back to help us take care of our patients. So in terms of what happened at ASCO for metastatic breast cancer this year, I would say that there was nothing earth-shattering. However, there was a lot of progress. And there was a lot of progress in understanding how metastatic breast cancer develops and how it grows. And also there was a lot of understanding in new ways to treat it. So I would say if I had to think about how I would label it, I would say that there was a lot of incremental knowledge, but there wasn't anything that was enormously practice changing. And I think what we do is that because 2005 was such a big year for us, when we saw the adjuvant Herceptin data, that was truly practice changing, that's our benchmark these days. So anything that's less than that, we always feel like, okay, need to do better. But I would say that many of the things that I'm going to show you really are beginning to change how we approach metastatic breast cancer, and that in and of itself is important. So there are a lot of women living with metastatic breast cancer. If you look at this paper that was published a couple of years ago, what you can see is that the number of women living with metastatic breast cancer is really increasing quite a bit. And in 2020, about 170,000 women are expected to be living with metastatic breast cancer. And, as you can see, people are living longer. And the way that we think about metastatic breast cancer, when we start to think about treatment, we think about it in terms of molecular subtyping. So we think about treatments and think about breast cancers as the hormone receptor positive or luminal breast cancers. We think about another category, and that's the biggest group. That's about 60% or so of breast cancers. We think about the HER2 positive breast cancers as the HER2 directed breast cancers, and we think about strategies to treat them that always have to include something targeting HER2 new. We think about these three little bubbles here as pretty much triple negative breast cancer, but there's a lot of overlap between the basal-likes and the triple negatives, and there are a large number of the BRCA1s in particular that are associated in here. So, we think this is how we sort of think about breast cancer when we start to pick some of our treatments. And this is how we've thought about it, I'd say, from about 2005 to maybe about 2015, 2016. But now what's happening is that we're starting to even get a little bit more granular than just this, and we're starting to think about pathways. And a lot of the data I'm going to show you today is really thinking about the pathways. So even though we're thinking about a HER2 positive breast cancer, we're thinking about a HER2 positive breast cancer perhaps with a PI3 kinase mutation or a MEK mutation. So this is, and you're going to see a lot of the therapies are really integrating this concept of pathway targets. And so what that means is that the lines between how we think about treatments, specifically lines between tumors, are really starting to blur. So for example, there was a drug that was approved, say about a year ago, pembrolizumab, that wasn't approved just for a specific indication for, like, say, breast cancer. It was approved for tumors that had what we called a genomic instability. So you can have genomic instability across multiple tumors. So it was sort of taking a big overview of breast cancer, of cancer, and not just, well, it's breast cancer, it's lung cancer, it's colorectal cancer. So the lines are blurring. The lines are blurring between all the different treatments, and that's really what you're going to see. So when we think about how we treat metastatic breast cancer, we think about it in terms of two ways. We think about it in terms of standard treatments, and we think about it in terms of clinical trials. And we think about choosing treatments. You can go between those things depending on the situation at hand. But when we think about standard treatments, I always like to think about it as choosing from 4 different buckets. So the first bucket that we think of is, well, can we choose something from the hormonal bucket? And patients who have tumors which are either estrogen or progesterone receptor positive are certainly candidates for hormonal therapy. And drugs which are in that hormonal bucket are things like the SERMs or tamoxifen, the aromatase inhibitors, and family members are anastrozole, letrozole, and exemestane, and the SERDs, and that's a selective estrogen receptor downregulator, which is a drug like fulvestrant. The second bucket that we always think about for treatment to pull from is radiation therapy. And I always say that radiation therapy only takes care of one particular area that's a problem. So for example, someone has pain in a bone, you can radiate it, that will take care of it. And I would say traditionally it's not thought that it treats your whole body, although I will say there is some emerging data that suggests that you can have systemic effects in the whole body from immune activation if you radiate in one site. The third bucket that we pull from is that we pull from chemotherapy when we think about treatments for patients with metastatic breast cancer. And there are many types of chemotherapies that we use. Some of them are pills, some of them are IVs, some of them you get once a week, some of them you get once every 3 or 4 weeks, but there's certainly quite a number of drugs in this bucket. And then the last bucket is the big expansion bucket, because every few months this bucket keeps on getting bigger, and that's the biologic therapy bucket. And for biologic therapy, what that is that those are genetically engineered molecules which target particular characteristics of tumor cells. And so those are things like if a tumor is HER2/neu positive, that would qualify as something being in the HER2/neu bucket. And so drugs that target HER2/neu, which is a growth accelerator present on breast cancer cells, are things like trastuzumab or Herceptin, pertuzumab or Perjeta, neratinib, lapatinib, T-DM1 or Kadcyla. Other biologic therapies are things such as the mTOR inhibitors, it's a drug, and the CDK4/6 inhibitors. So an example of an mTOR inhibitor is a drug like Afinitor. Examples of the CDK4/6 inhibitors are drugs like abemaciclib, Ibrance, and Kisqali. And the way those drugs have been developed have been to make hormonal therapy work better. However, these days, they're looking beyond just making hormonal therapy work better, and there are a number of clinical trials which are looking to utilize them in other diseases. Immunotherapy has been proven to be effective when combined with chemo for triple-negative breast cancer, so that's the only one right now, and we had some updates at ASCO this year specifically about that. PARP inhibitors have been shown to be effective in tumors which have a germline mutation, in BRCA1 and BRCA2. But what's interesting is that they're looking at opportunities to utilize them in tumors that have those characteristics, not just in patients with tumors that have those characteristics. So we're probably going to see more in that avenue. And then the newest kid on the block are the PI3 kinase inhibitors. Alpelisib was just approved, and that's targeting a particular pathway. And that was also combined with hormonal therapy. So these are like all the options we have in a big picture for patients who have metastatic breast cancer when we're trying to figure out how best to treat them. So what you're going to see now are many slides, which I pirated from the ASCO meeting and from some of the many very good talks there. And this was a talk that was given by Dr. Sunil Verma, who's up in Calgary, a colleague of mine. But I felt it really reflected a lot of how we treat endocrine therapy, and sort of will take us into some of the presentations that were at ASCO specifically in this area. So when we start to think about treating patients with hormonal therapy, you think about either giving hormonal therapy by itself or combining it with a biologic, specifically a CDK4/6 inhibitor. And so that would be considered first-line therapy. Second-line therapy, you would switch out the hormone and perhaps bring in another biologic. But what we saw at saw right coming into ASCO was that there was a PI3 kinase inhibitor that was approved, the alpelisib. And just to sort of show you that in tumors that have a mutation called PIK3CA, this is a mutation that basically is present in about 30% of all breast cancers. If you look at this is called a Kaplan-Meier curve. And this is the probability of progression-free survival over here, and this is over time. So the bottom line is that the lines on the top always are doing better. So the thing is when you see the blue line here, the patients who were taking the combination of the PI3 kinase mutation inhibitor, because these tumors have PI3 kinase mutations, plus the fulvestrant, their tumor was under control for much, much longer, about twice as long when they took the PI3 kinase inhibitor. And that led to its approval the week before ASCO. So that was sort of exciting. But there are a lot of other drugs out there to make hormonal therapy work better. And one of the updates we had at ASCO this year was to see the MONALEESA-7 trial. So the MONALEESA-7 trial, the MONALEESA trials are a series of trials that are done with a drug called Kisqali or ribociclib, which is the Novartis CDK4/6 inhibitor. And I would say for all the CDK4/6 inhibitors, they're really 6 or 1/2 dozen of the other. It's just they have different side effects profiles. So Sarah Hurvitz presented this study. And this was an updated study. So they already demonstrated that in this study that it could make tumors stay shrunk for a longer period of time. But we didn't know, just because it makes tumors stay shrunk for a longer period of time, does that make people live longer? And the bottom line is that yes, it does. So let's just run through the data. So what they did was that they basically enrolled 672 women who were pre or perimenopausal, so they were young. They randomized them to standard treatment with hormonal therapy versus hormonal therapy with ribociclib. And so they looked at the overall survival endpoint. And so what they saw was that, generally speaking, survival differences started to appear at about 24 months. But at 24 months, it appeared that the ribociclib really started to kick in, and the patients who got the ribociclib lived longer. And so what we do is that we look at medians. That's how we look at our data. And so we'd say that the median survival of someone who didn't get the ribociclib was about 40 months, but that hasn't been reached yet with the ribociclib. So we also look at stats in these trials, and these are things which would be considered statistically significant. So that means it's not due to chance. In terms of, and it's interesting, it's because similar, they got 2 different kinds of hormones in this group. They got either tamoxifen or an aromatase inhibitor. And similar to most of the trials that have ever been done, the aromatase inhibitors always do a little bit better, and that's what you can see here. So it might be really good to combine the ribociclib with an aromatase inhibitor. It was just a little bit better. So the other thing that they looked at in this trial was that they looked at, well, how can, if we give patients ribociclib, can we delay time to chemotherapy? Because eventually patients end up on chemo, and they found that they were actually able to delay the start of chemotherapy in these patients. So most people would feel that that is a sort of a good endpoint. So, for example, on average, patients who enrolled in this trial started chemo about 3 years later, and they haven't reached the median time to chemotherapy start with the ribociclib arm yet. So this was actually the first trial that showed a survival benefit with the addition of with a CDK4/6 inhibitor. And when we looked at side effects, the side effects are pretty typical for this family of drugs in that they can lower the blood counts a bit. The ribociclib has a particular characteristic in that it can alter the conduction in the heart a little bit, because the heart is an electrical organ. So you have to do a couple of EKGs at the very beginning. As you can see, it's less than 2%, but we keep an eye on it. So the bottom line is that ribociclib and hormonal therapy improves outcome in women with metastatic breast cancer. So that was that was good information. So the other thing that we saw in terms of can we make hormonal therapy work better was that there was a drug called capivasertib, which was combined with fulvestrant. And basically this is an AKT inhibitor. And, we talk about pathways. And so basically when we talk about pathways, figure, this is AKT, this is where it inhibits it. So in this study, what they did was that, and this is sort of an early study, they basically looked at women who had been on an aromatase inhibitor, and then their next hormonal therapy they were going to go on was fulvestrant. So they gave half of them fulvestrant, and they gave half of them this AKT inhibitor called capivasertib. And so basically what they found was that if you look at the red line here, is that the capivasertib worked more than twice as good at keeping tumors under control than the fulvestrant alone. So that's where we look at the medians here, so 4.8 months versus 10.3 months. So this means that the drug is working. When they looked at, did it make tumors shrink more? other than just keeping them under control, that's when we look at things called the objective response rate. So basically what we saw was then when patients just got the fulvestrant alone, 12% of them had a 30% shrinkage in their tumor size. But when they added the capivasertib, that they were able to increase that by more than 3 times. So so that would be considered something that would be valuable. So all of these things are pretty positive. In terms of side effects, always sort of looking at side effects, and the side effects as clinical researchers that we always really pay attention to are the grade 3 to 4 toxicities, because those are considered severe toxicities. So when you look at the severe toxicities, what you can see is that increased shrinkage of tumors as well as the longer duration of response comes at a cost of more diarrhea. So when you look at the diarrhea, capivasertib, it's about 14%, and you can get a rash. So these are sort of the kinds of side effects that we actually see with Xeloda or capecitabine. So these were the side effects that we saw. So so this is a drug which is probably going to be added to, going to be developed a little bit further because it works a little bit differently. But when you think about drugs which are added to fulvestrant to make it work better, it's the mTOR inhibitors like Afinitor, it's all the CDK4/6 inhibitors, it's the alpelisib, which is the PI3 kinase inhibitors, and now we have the capivasertib. So there are lots of different options, and that's really good because when you think about treating women with metastatic breast cancer, you think about maybe keeping them on fulvestrant and just swapping out the biologic, and perhaps you can get more mileage out of those drugs. And of course, that all delays starting on chemotherapy, which usually most people are interested in doing. So let's talk a little bit about HER2-positive breast cancer. So HER2-positive breast cancer is a little bit different from a lot of the other breast cancers that subtypes of breast cancer that we deal with, in that there is a very sort of clear what you do first line, second line, and third line. And that's because it's driven by survival. So we know that if we give pertuzumab, trastuzumab, and docetaxel, which is called the Cleopatra regimen, that we improve survival by 18 months. So even though patients develop hair loss, which is, we don't like to sort of have that side effect when we're treating metastatic breast cancer, we do that in the HER2 setting because we know that will improve survival. Second line therapy is Kadcyla or T-DM1, and then we usually use capecitabine and lapatinib or other chemo with Herceptin as third and later line of therapy. And just to make sure we're all on the same page, HER2/neu is a growth accelerator which is present on breast cancer cells, and it's important to know about it because all these HER2-directed therapies can really neutralize it. So at our metastatic breast cancer session, at ASCO this year, we actually had 3 presentations looking at new drugs in the HER2-positive space. One of them was the SOPHIA trial with a drug called margetuximab, and margetuximab is sort of I don't want to call it a designer Herceptin, but sort of a designer Herceptin. There was pyrotinib, which was sort of a new and improved form of capecitabine, and that's, of lapatinib. And neratinib is also a new and improved version of lapatinib. So those are the presentations that we saw. So first, let's look at the pyrotinib study. And what was sort of interesting about the pyrotinib study was the fact that, I think in the US, we take it for granted that we have access to a lot of drugs, because when you look at the study design, you will see that a study like this would never happen in the US because we have second and third line therapy. But in China, where it was undertaken, they didn't have all these other lines of therapy. So pyrotinib is a small molecule irreversible inhibitor of HER2/neu, EGFR, and HER4. And so basically what that means when you have EGFR being targeted also is that basically that means you're going to get some diarrhea, you're going to get some skin rash, because those are receptors that are present in those organs. So in this study, what they did was that patients who had HER2-positive metastatic breast cancer who had progressed on trastuzumab were randomized to either pyrotinib and capecitabine or capecitabine alone. And so what they found is that when they got the combination therapy, the capecitabine and the pyrotinib, they did much, much better than getting the capecitabine alone. In the US, you would never have a trial where you would get a chemo drug without a HER2-directed therapy. But in the venue where this trial was conducted, that was considered a standard. So as you can see here is that it made the pyrotinib, the HER2-directed therapy, made the chemo work 3 times as well as you would expect. And this just really shows you how important it is to get, if you have a HER2-positive breast cancer, how important it always is to have some HER2-directed therapy on board. It makes everything work better. And this is something else that we always have in our presentations, and these are called forest plots. And basically, you know, what this tries to give us some insight into is there a particular characteristic present either in a patient or in a tumor that makes a drug work better or worse. And the bottom line is that anything that crosses this one means that it's not that interesting, but anything that favors pyrotinib without crossing that one mark usually means that there's a benefit in that group there. So what you can see is that for most, categories, patient-related categories, you can see that it favored pyrotinib. So there wasn't one group that really didn't benefit. So we talked about how it made when you put the combination together, it made it work a lot longer, but it also shrunk tumors down a lot more. So if you were to look at the response rates for the combination, it was 68% versus 16%. So that's a really big difference. So it made tumors shrink better and made them stay shrunk longer. And in terms of always at what side effects, and as expected, what you can see, again, looking at, remember we'd always talk about how what we focus in are the grade 3 and 4s, is it's diarrhea and hand-foot syndrome. And so remember we had said that this is sort of like like lapatinib. So these are the kinds of side effects that we would see with lapatinib, except that I would say that the diarrhea in this for this drug at 30% is more than we would typically see with lapatinib. So in summary, I would say that these 2 drugs are effective and, you know, moderately well tolerated. So let's talk about the other lapatinib drug, or the other lapatinib-like drug. It's called neratinib, and neratinib's been around for a while. And so this trial is actually called the NALA trial. And so in this trial, this was run in the U.S., mostly in the U.S. These were patients who had metastatic HER2-positive breast cancer who had at least 2 lines of therapy for metastatic breast cancer. And the trial design was similar in that they got neratinib and capecitabine versus lapatinib and capecitabine, which is our standard 3rd-line therapy here. And so what you can see is that first of all, between the patient characteristics, as we always say, they're evenly matched, right? Because otherwise, how can you compare them? But also what you can see is that about a third of the patients had at least 3 lines, 3 other HER2-directed therapies. So this was an interesting trial, the way that they analyzed these data, because really you don't really see any differences between the 2 arms until about 6 months. And so the way they did their statistics was that they really looked at the differences between 6 months and 12 months. And basically what they saw was that that neratinib and capecitabine kept tumors shrunk longer than the lapatinib and the capecitabine. And if you look at 12-month mark, 29% of patients were still on the investigational drug, of twice as many as compared to lapatinib and capecitabine. And if you looked at the response duration, you can see that patients did much better who were on neratinib and capecitabine. There was no difference in the numbers of patients who actually had their tumors shrunk, but the difference was really seen in how long it kept them on that drug. Again, this is a forest plot, and as you can see that it seemed like patients who had hormone receptor negative tumors did a little bit better. Patients who had non-visceral disease did a little bit better. And this just gives you a little bit of sense. Again, looking at the grade 3 and 4 adverse events, you can see diarrhea and hand-foot syndrome. It's really the diarrhea that was more prominent with neratinib as expected. And they have a very detailed anti-diarrheal prophylactic regimen built into this drug, because that's the real problem with this drug. But if you follow it, supposedly it works well. So basically, I think it's unequivocal that neratinib is really a better tyrosine kinase inhibitor than lapatinib when combined with capecitabine. So talking a little bit about the designer trastuzumab, that's where margetuximab comes in. And so basically, when you talk about trastuzumab, this is what it looks like. There are 2 parts to the molecule. When you take it apart, there's things they call the FAB fragment and something called the FC fragment. And the difference between the trastuzumab and the margetuximab is the FC fragment. And so basically, this is engineered to really target this CD16A, because supposedly trastuzumab doesn't really bind well to CD16A and of HER2/neu. So this is, as I say, a designer trastuzumab. So what they did in this study was that they basically took women who had had a lot of prior treatment for HER2 positive breast cancer, and they said, you know, these are the 4 chemos you can give, pick one, and then we'll flip a coin between trastuzumab or margetuximab. And then we'll see how well it keeps things under control. And so, interestingly, there really wasn't much of a difference between the designer margetuximab or the trastuzumab. As you can see, these curves are very, very, very close, with the blue being the margetuximab and chemo, and the green being the trastuzumab and chemo. And in fact, the difference was less than 1 month. Even when they actually looked at tumors that had this characteristic, they felt that was really a good fit for the margetuximab, there was a little bit of improvement, but not a lot. It was statistically significant, but I think most of our colleagues would say that this was not a big difference. It was 1.8 months. So I think that, and there was no difference in the and how well it shrunk things down, and side effects were pretty much the same. So I would say that this is the first pass of the data. I'd say it's interesting, and I think it definitely needs more work. You know, some people might say, "Oh, forget about it. It's not worth it. We're looking more at it." But you know, I would say, you know, sometimes it takes a while to figure things out. So stay tuned. So in terms of triple-negative breast cancer, there wasn't a lot in triple-negative breast cancer. There were some interesting survival data. So as I mentioned, so this was survival data from the atezolizumab study in triple-negative breast cancer. So in that study that was presented, I'm going to say at ESMO, and the immune data was presented at San Antonio this past year. This was the study that led to the approval of atezolizumab, which is the first immunotherapy in breast cancer. So this was a first-line study of patients with newly recurrent triple-negative breast cancer were randomized to atezolizumab and nab-paclitaxel or Abraxane, given weekly, versus Abraxane. And so what they found in the original study was that there was a slight improvement in patients, you know, in the entire population who got the combination therapy, as shown here by the blue line. But when they actually looked to see which tumors had positive staining for PD-L1 on their immune cells, not on the tumor, but on their immune cells, they saw that they got a little bit more bang for their buck out of the atezolizumab, and that there's a 2.5-month median improvement in how long it kept the tumor shrunk. So that's what led to the approval of atezolizumab and Abraxane for PD-L1 positive immune staining in triple-negative breast cancer. So this was a report on the survival outcomes in that trial. So if you, again, since we know it really only works in the PD-L1 positive immune cell population, they presented data on their on the overall survival in that population. And as you can see, there's a 7-month improvement in patients who do receive atezo who have PD-L1 positive. So now some people might say, well, you know, a 24-month overall survival rate is, you know, 51%, you know, that's not so great. But I would say that they've doubled the overall survival rate, because the median survival for triple-negative breast cancer is 12 months. So they've just doubled it with the addition of atezolizumab. So I think it's a good step forward. Of course, a ton more to do, but it's a good first step. So so in terms of I think I'm not sure that we and this is where I wanted to just sort of spend maybe about 5 more minutes on some of my current research, because the organizers of the conference asked me to share with you some of the work that we're doing. So those were the highlights from ASCO. So I've done a lot of work in drug development. I've done a lot of work in what we call the tumor microenvironment. And, you know, we've just spent about 40 minutes talking about metastatic breast cancer. But really what my focus of research is on is how to try to prevent metastasis. And so when you start to talk about metastasis, you start to talk about the tumor microenvironment. And there was this guy whose name was Dr. Stephen Paget, and we're still talking about his work from 130 years ago. He was a surgeon in London, and what he noticed was that metastasis have a propensity to go only to certain places. And the way he sort of talked about it was that the seed in the soil had to sort of have a good fit. That certain seeds had an affinity for certain environments or organs. And, you know, the soil had to be right, and that metastasis only happened when they were compatible. And this sort of concept has really percolated through scientific discovery over the past 130 years. And so I would say that the current strategy, you know, and what we've been talking about has really been to target more seed than soil, because we talk about, you know, targeting molecular targets and pathways. However, and we're targeting clonal abnormalities. But I would say if we could pull out the infrastructure that tumors needed to spread, well, then we really wouldn't have to worry about what we're targeting and the development of resistance. And so pulling out infrastructure is like pulling out, is sort of like having a car that has no gas in the tank. You know, it has no place to go. And that's really a lot of the work that I had done when I was at Cornell for 15 years, and now that I'm at MSK for just a little under 2 years. So, I have doubles. Okay. So this is how we think tumors spread. And we've actually done a lot of the scientific work in order to prove this. So for example, we know that there are cells that come from the bone marrow that are hypnotized, and they leave a trail for tumor cells to follow to a distant metastatic site. We've proven this. And so when the tumors get to that distant metastatic site, they need a welcoming environment to land. But the problem is that the doors are shut when they get to that welcoming environment, because these places don't want them there. So then what happens is that there are enzymes that are activated to sort of make a welcoming environment. They sort of soften up a place for tumor cells to land so that tumor cells can go in. But when they get there, there's no place for them to land. So what happens is that collagen creates a scaffolding, a sort of a landing pad for it to land. And we call that the pre-metastatic niche, so it can just go and sit down. Once it gets there, though, it doesn't come with a suitcase. It needs infrastructure to grow. So what it does is that it calls in infrastructure in order to develop a tumor. So the issue is, you know, if we could stop any of these steps, could we prevent tumor spread? And so around 10 plus years ago, we had this idea to pull out the infrastructure that the tumors needed to spread. And I'm not going to go through all the details, but we identified copper as a target because copper was integrally involved in all these different steps. And then because we're clinical trialists, we said, well, let's do a clinical trial in order to see if we can prove this. So what we did is that we designed a trial that we initiated in 2007, where we gave an oral copper depletion compound to women at high risk of breast cancer coming back after they completed standard therapy. These were people who had done everything they needed to do, but they were looking for something extra. And so the idea behind it was that copper is critical for multiple biologic processes necessary for tumor spread. And so what we wanted to do is that we wanted to copper deplete our patients, because copper is important where normal cell function could take place, but where copper-dependent tumor processes could not. And so we designed a phase 2 study of a copper depletion drug called tetrathiomolybdate. We enrolled 75 patients who were at high risk of relapse. And these were patients who had stage 3 breast cancer, those who were stage 4 without any evidence of disease. And then after we got a signal that there was something special for copper and triple negative breast cancer, we actually extended our enrollment to enroll stage 2 triple negative breast cancer patients. We gave our patients copper depletion pills for 2 years, and then we looked at the effect on the tumor microenvironment. And the tumor microenvironment were a bunch of things. So these were some of the cells that call in the infrastructure. These are some of the enzymes which basically soften up the environment so tumor cells can land there. And then that's also ultimately, that's the collagen scaffolding the tumors like to land on. And we basically found that copper depletion affected all of those steps. And it was really what made us look at all of those things was the fact that it was very unusual for our patients to relapse while on that study. So in terms of like, how did our patients do on this study? Well, they did well, most of them. We found that copper depletion was safe and well tolerated. We found that there were many less tumor recurrence than would have been predicted. And so that actually led us to go back to the lab where we've done a lot of work in order to really understand how copper affects all of the different steps that are involved in metastasis, including invasion, migration, metabolism. And we've demonstrated, at least in the lab, that we pulled out some of the infrastructure that tumors needed to spread. And then what we did is we went back to our patient samples, which are actually, our patients come to see us once a month. We draw their blood and then we stick it in the freezer. We went back and we checked all the blood in the freezer. We found out we were doing the same thing in our patients. So when we go back and we think about this model and we think about all the different things that we're affecting, well, we know that in our patients and as well as in the mice, we know that the enzymes that condition the pre-metastatic niche, such as enzymes called lysooxidase, are completely abrogated both in our mice as well as in our patients. It's reduced by more than 50%. So we know that the area isn't softened up for them to go to. We also know that in our mice and in our patient, the collagen scaffolding is affected. We also know that in our patients that the infrastructure, they can't call in the infrastructure to grow, and that infrastructure actually has a name, and that's called VEGFR2 positive endothelial progenitor cells. Those are the cells that put down the blood vessels that allow nutrients and all sorts of stuff to come through the tumors and then allow the tumors to spread. So then the idea is, are we preventing metastasis? And so what we're doing is that we are now moving to a randomized phase 2 study within the MSK network and also the Translational Breast Cancer Research Consortium as a next step. And so we're pretty excited to get that going. Everything takes too long, but we're really hoping to help to, not to have to talk about metastatic breast cancer because we'll have a strategy in order to prevent metastasis. So in conclusion, so that's just some of the work we're doing in what we call the microenvironment. So in terms of conclusions, as you can see, there's a lot of work being done. There's a lot of information. It changes literally every 3 months. I would encourage you all to stay abreast of things, stay engaged. And as I always tell patients, it's always important to stay well until the next big thing comes along. And even just, in terms of something like a PI3 kinase inhibitor, when I think about, now I have a drug where I can now recycle a hormone with many of my patients who have PI3 kinase mutations, I'm happy, they're happy. So with that, I guess we can take some questions.
Thank you, Dr. Vahdat, for your presentation. We'll begin the question and answer period now. Please type your questions into the question pane on your screen. Please keep in mind that not all questions submitted will be asked due to the clinical nature of some of them. If you submitted a question and do not hear it, please feel free to call the SHARE helpline 844-ASK-SHARE, and a trained volunteer will be able to help. And now some of the questions that we have received. One of them is, can some patients just be on hormonal therapy without adding other drugs?
Yes, absolutely. And we did that for many years. And even now I have a lot of patients who are just on hormonal therapy without adding in one of these other drugs. The only thing is, because you definitely, when you add in those other drugs, you do definitely add in toxicity. There's no doubt about that. but you do add in some efficacy. So it's always a balance.
Thank you. Also, another question that came up is, when should we act for genomic testing, and should a metastatic breast cancer patient have genomic testing on every new metastatic site?
So I feel that genomic testing absolutely has to be done on every single, at least once during a metastatic breast cancer patient's trajectory. I mean, I feel like not doing it is really, really bad. Now, sometimes, based on, logistics, so like where the metastasis is, maybe you can't get enough tissue, you can't do genomics on a fine needle aspirate, but that's where circulating tumor DNA comes in. So ctDNA is not as good as actually sequencing the tumor, but it's like the next best thing. So I would absolutely I would absolutely do genomics on a metastatic lesion. And I would say that, if you go through a biopsy, you should probably always sequence it. You're probably not, the thing is, I always say you get surprised, and sometimes you get targets you wouldn't otherwise think, which lead to opportunities for treatment.
Thank you. Someone is asking, should all metastatic breast cancer patients be tested for a PDK mutation and or a PDL1 mutation?
So I'm not sure what a PDK mutation is, but a PDL1 right now, what we're doing is we're just doing it in our triple negative breast cancers.
Is there a reason?
It hasn't really been shown, immunotherapy, even in the PDL1 population, has not been shown in the ER positives yet, but that's going to change. I know that's going to change. It's just I feel like we're not there yet.
Okay.
I almost feel like tumor mutation burden is like a better marker, so this is where sequencing comes in. So if you have like lots of mutations, you can have a high tumor mutation burden, and that alone can predict, it's looking like that is a good marker for prediction of benefit from immunotherapy.
Great. Was there anything at ASCO concerning lobular metastatic breast cancer?
I didn't see anything on lobular.
And what is happening with the PARP inhibitors in their longevity for breast cancer patients whose cancers have become resistant?
Yeah, so it's interesting. So with the PARP inhibitors, one of the things that we know is that there is a survival benefit when it's used first line. They don't see a survival benefit when it's used second and later line. That's coming out of the Embraca trial and the Olympiad trial, the two trials that led to the approval of olaparib and talazoparib. But I would I sort of look at those drugs as, additional therapies. There were a couple of other drugs which were being developed for patients who had germline BRCA mutations, but I haven't seen anything recently. Like one was a drug made by PharmaMark called lurbinectedin. So I haven't really seen, and I've been looking because obviously I have we all have a lot of patients who have germline mutations in BRCA1 and BRCA2. So I haven't seen anything over the past year, beyond PARP inhibitors for those patients.
Okay, thank you. And someone's asking about, is conventional oncology willing to consider adding well-documented alternative support options?
It all depends on what they are, I think. The thing is that, I think most oncologists like to use data to guide what they do. And so like, for example, you talk about acupuncture. Now you have very good data on acupuncture in terms of symptom management, really. So like, people are interested in recommending them and saying, listen, this will help you because the studies have been done to show that it will help you. I think when you don't have studies, even one study to demonstrate efficacy, I think that's when the alternative stuff sort of falls down, because oncologists tend to be very data driven.
Okay, and someone is asking regarding the genomic testing in this setting, Is it always approved for payment through insurance, Medicaid, Medicare?
I believe so. Breast cancer is one of the indications, so it should be paid for at least once.
Okay. Another question was, are life expectancy statistics improving?
Yes, very much so.
And then, can you speak a little bit more about what you mentioned about the on-site, the radiation?
So in terms of like radiation, and then not just radiation effects at the site, but distant site?
Yes.
Yeah, so that's sort of interesting. So there's something called the abscopal effect. And Dr. Fermenti, who's a radiation oncologist, she was at NYU for many, many years and then moved to Cornell when I was there. And she had demonstrated, not only in the little mice, but actually in people, that you could radiate one lesion that got smaller, but then distant lesions would also get smaller. And it was felt that when you sort of zap that one lesion, bits and pieces of it sort of break down, and the immune system gets a hold of it, and it like revs itself up, and then it fights the cancer. And so they've actually worked out a lot of those steps in the lab and actually in people. And so there are a number of clinical trials out there looking at that specifically.
Yes, we've worked with Dr. Fermenti. Okay, and I think I have a last question here. Is there any benefit to using copper depleting drugs when you are not triple negative, but not showing any evidence of disease?
Yeah. So we're actually trying to figure that out. So we're trying to figure that out. So there's a biomarker that is present. So the thing is, one of the things that we know is that copper is important for cells to move around. So like, for example, copper comes from, it's almost like when cells move, they move sort of like for the older people on the call, like a slinky. I don't know if the young people know what a slinky is. And the thing is that copper gets translocated from the nucleus to like the edges of the slinky, to the extending edges. And the thing is that a special protein carries it there. And so it might be that special protein is not present in all breast cancers, but some breast cancers, and a lot of triple negative, but there are some other like hormone receptor positive breast cancers, probably, yes. Probably not so much in HER2 positive. And so we're looking into that in a cohort out of our TM trial in order to try to understand that. So.
Okay, so we'd like to thank you, Dr. Vahdat, for an informative program and for all that you're doing for patients. We want to thank everyone for your participation, and we'd like, if you would like to see more programs of interest to you, please take a moment to fill out the survey at the end of this webinar. Also, we'd like you to know that Share has a new app, and it's called My Metastatic Breast Cancer and Me, and you can get that for free. And we also have different programs, educational programs that are coming up, including a topic-driven roundtable for DCIS. And once again, Dr. Vahdat, we really want to thank you at Chair for all you do, for the women that you serve, and for your helping us to make sure that we're able to educate as many people as possible about breast cancer.
Thank you very much for doing this. I think it's terrific.
Thank you.
Dr. Vahdat, can you still hear us?